You want?
Okay, hi, welcome everyone. So we are really pleased to start and launch our first Understanding Behavior virtual workshop series. So this came recently across a team of people really focusing on understanding behavior. So Daniela, Christophe, Marion, and myself, Damien, we really wanted to use the behavior forum and use it as a tool to improve and enhance the way we currently do scientific communications and webinars. So the idea is that today and for the next workshops, you will be able to connect on the forum. So I hope you already did. And before the webinar, we actually posted a topic with the title and the subject and the presentation of the speaker, and you can already try to think and discuss, and if you have any questions about this topic, you can ask them before the webinar. Then we as moderators today, so we are a team of 4, and we will be taking those questions into account, and then in the discussion those questions will be included. If you did not do it, it's not too late. You can actually connect now. There is the QR code if you want to follow the link to the forum. You can connect and then find the topic of the webinar of today, and you can ask your questions during the talk. There is no problem. We will be there live and we will take into account all of your questions. Do not use the chat from the Zoom. You can directly go on the forum and ask your question there, and they will be included for the discussion that we will have later on with Emma. And after, we want to follow up. And if you have any question in 1 week, you can still ask it, and we will be following the discussion. And hopefully next time, maybe Emma or another speaker that is continuing on this modeling depression-like behaviors in rodents will follow up, and then maybe your question will be answered, and we can build the next workshops based on those comments. So I think this is one of the main question here. So maybe now I just show you for those of you that have no idea what is the Behavior Forum. It is a discourse forum where you can ask anything that you have in mind concerning animal behavior protocols. If you have some newspapers you want to share, if you have questions about the protocol, if you developed a protocol for a behavioral task, if you have some software issues, animal welfare questions, if you want to share an event, a meeting, or even if you're looking for a job or if you have a job opportunity, anything related to animal behavior can be shared in this platform. It's open, it's free. So you just have to sign in to register because of the security issues, but it is completely free. And as soon as you're logged in, you have access to everything, and it's really a nice community. And with this community, we provide you now this virtual workshop series. So I really hope that you will enjoy as much as we are excited to host it today, the Understanding Behavior.
Yep. Okay. And so thank you, Damien. This virtual workshop series, we are planning to do them every 2 months. So today we are starting with the topic of modeling depression-like behaviors, and we will discuss it with Amma. And then after, we are thinking also, because this is a consortium about home cage systems in rodents, so we are also planning to have workshop series on home cage systems. And another one that is kind of important, that's after, like, what we do with all this data and how to analyze the behavior that we get. So this, I want to stress out that these are potential topics because we really want you to be involved in this community and also suggest topics, suggest speakers, suggest things that you want to discuss with us, because the idea is that this is an interactive series. So after the presentation of Amma, we will discuss really these concepts of behavior, and sometimes there is not really like a correct answer. So we are kind of here also discussing and analyzing the state of the art of all of these components. And so if you go to the forum, there is already there on events, meetings, and training, one topic for understanding behavior called for topics and speakers. So if you think the next series we should talk about something specific, go there and just make your suggestions. So for the talk of today, that is modeling depression-like behaviors, there is different tests that are being used in the literature. Namely, the most famous ones are related more with what we could call behavioral despair, that is the forced swim test and the tail suspension test. Then there is the learned helplessness test that is also being used as a model of depression-like behavior in animals. And then there is more tests that are more related to the concept of anhedonia, like the sucrose preference test. Emma today is going to mention more the cognitive aspects of these tests and how can we, for example, with the affective bias tests, can actually measure maybe in a different way or more, let's say, integrated this concept of depression in behaviors. And Emma, Emma Robinson. She comes from the University of Bristol. Thank you so much for accepting our invitation. It's a really great pleasure to have you here with us to discuss behaviors. And she's particularly interested in the neural and neurochemical mediators of cognitive and emotional behavior, and how they can be disrupted in psychiatric disorders. She's also very interested in objective measures of affective state for better understanding animal welfare. And this is even actually one of the key words we put it, the 3 H's that Emma created this initiative for handling, housing, and habituation. She's also really into psychopharmacology and rats. And I actually met Emma the first time during a conference on psychedelics. So she's really in the front of what is going on with the field in terms of behavior. And with that, I want to give Emma the stage. And thank you once again, Emma. I will stop sharing.
Thank you. I'll share my slides. Hopefully that will all work. Everyone can see that, I hope, if it goes to full screen. There we go. And find a laser pointer. So yeah, brilliant. Thank you very much. And as I say, this is really quite an interesting topic, isn't it? There's a lot of sort of controversy in some ways around modeling depression-like behaviors and some of the tests that have been used. And I was just chatting about this before we started, about how I think it's a really important thing for the field to discuss. We need a sort of a bit of a consensus about how we should be best approaching this. So I'm going to talk to you about some of the sort of tests that are currently being used, and particularly some of the work we've been doing, looking at how we might develop new approaches for modelling depression-related behaviours. And just to disclose, so I'm based at the University of Bristol, but we also, just to disclose, have a couple of conflicts of interest. I work quite closely with a couple of pharmaceutical companies at the moment, both Boehringer Ingelheim and Compass Pathways. And in the past, we've worked with various other organisations, Pfizer being the main one that was involved in helping us develop the assays that we're using. So I'm going to start off by sort of talking about my view on challenges and what I think are the problems of modelling major depressive disorder in non-human species. And you're going to note, hopefully, that there's been a lot of blame put on animal models, and I'm not entirely going to let that stand. I think we have to think about this much more broadly, and generally just how we are trying to quantify depression in animals, but also in humans. But as many of you will be familiar, so animal models are defined by their face. Do they look like the human disorder construct? Do they have the same underlying biology? They're predictive. Do they predict drugs that are going to be effective in patients? And perhaps most importantly, their translatability. Does what we do in our animals translate to humans? And these are quite challenging things, because most of what we talk about in psychiatry is based on subjective self-report. So we can say it sort of looks like it, but it's never going to align directly with an animal. Construct, we don't have any biomarkers, although some people might argue that there is things like BDNF, or they're not specific. We don't have a clear cognitive or imaging biomarker, a clear blood or imaging biomarker that we can use to establish construct validity. Predictive, yes, there are some good bits with animal models. And whilst we're going to talk probably a little bit negatively about this for some of this talk, I don't want to forget that actually second generation antidepressants came about because of these conventional screening tools that we were using in our ability to develop drugs which lost the safety issues of tricyclic antidepressants, that were more selective, had better side effect profiles, and you know, they came out of tests like the 4-swim test. So I think we must remember that. However, I think as time has moved on, and as we've become more we're asking different questions, that's where these animal models become more limited. But the big problem is, in psychiatry, we have no clinical biomarker. We don't really understand the etiology in humans, and all our drugs that we use are actually based largely really on serendipitous drug discovery. So we found the drug long before we found the pharmacology or how it worked, and so we are effectively always playing catch up. And of course, the symptoms are primarily behavioural, which is of course great. Why, you know, people who specialise in behaviour, this is our job to solve. But equally, it is a quite difficult thing because behavior in itself is so complicated. And as already very kindly introduced, this is the sort of overarching kind of framework we work with at the moment, are what I call them as conventional assays. These are the kind of, if you were to Google what assay should I use, this is what's going to come up, something like a sucrose preference test. So this is, can an animal detect and therefore prefer a sucrose solution, a low concentration sucrose solution? And then we have our 4-swim tests, a sort of all tail suspension, behavioral despair. Or quite often, actually, the other one that's used is novelty suppressed feeding, which is probably more anxiety-like, but it's still quite commonly used in the study of antidepressant drugs more generally. Of course, in humans, we use subjective self-report measures, and that's largely how human disease is defined. And at the end of the day, subjective self-report measures in patients are never going to equal behavioral changes in these assays, not without some anthropomorphism. So the two will never fully align. I wanted to take this opportunity also to highlight some more factors that I think we should be taking into account when we're thinking about translation. So obviously, we've got this behavioral readout issue. Ultimately, no matter how clever your molecular, cellular, any of those cool neuroscientific techniques you're going to do, if you want to relate it to depression, then ultimately you need a behavioral readout. There is no other way of doing it. And we need innovation. I absolutely think we need innovation in that. And innovation in behavior is difficult and expensive. It's taken us sort of 15 years to get where we got. And the problem is that most of what we're working from otherwise is what I would call pharmacological assays. So we quite often talk about them as a model of depression, but things like even, you know, a model of to test antipsychotics, you use locomotor activity, but locomotor activity is not specific. It's not it's not really directly translatable to what's going on. It's just that drugs which are antipsychotic will attenuate stimulant-induced locomotor activity. So it's a pharmacological tool. And in many ways, the 4-swim test is actually very similar to that. The 4-swim test is a test that Paul Salt developed so that he could test for drugs that were going to be like the tricyclic antidepressants, monoamine oxidase inhibitors, and he could differentiate their effects in the 4-swim test from a range of other compounds. But he always said, watch out for amphetamine because of its locomotor effects. The real problem is that although these may be predictive models and be suitable for predicting certain types of drug, we have no evidence at the moment that they engage relevant underlying mechanisms. And actually what happened is they started being used in phenotypic studies. And that's where I think the real problems have started, that they are not really validated as phenotypic models. And therefore, we don't really know whether they're therefore engaging the relevant underlying mechanism that translates to humans. The other thing is, I don't think we've recognized those limitations, and probably that's driven by, you know, a lot of the sorts of biases that exist. We have to try and, you know, we've got to make a nice story for our publications. So we talk a lot about mechanisms, the underlying mechanisms, and that the behavior is either depression-like or it shows antidepressant, you know, potential efficacy as an antidepressant. And of course we're going to interpret our data like that, but as a whole, when you look at the larger data set, I think there are clear limitations in that. And of course there's other stuff that if it's not just specific to our depression, we've got to think about our reproducibility and sort of sample sizes and stuff. The great thing about the 4-swim test is that it's very well powered. You know, it's got an effect size of sort of 3. It's huge. And it also is something pretty much everybody can do in every lab, and that's why it's very popular. But it's not necessarily biologically relevant effect size. And when we're doing these studies, we also have to think about how do we consider things like methods to avoid bias, making sure it's very clear how we're reporting it. And the one that I'll talk a bit more about is appropriate dose selection, because actually what I'll also show you is that the majority of forced swim test studies are actually using doses of drugs that far exceed the clinical occupancy you're going to see. And I think that's quite a problem as well. The other one that's recently we've been talking about a bit more is what is normal. You know, depression is a disease that is caused by environmental factors, stress being the main precipitator. And these are just really common part of everyday laboratory animal management. So how much do we already have a depression model? Is the animal model that we all have in our lab actually a depression model? And maybe what we should be focusing our attention on is a better control. So there's just things for you to think about. The importance of dose. This is an area we've been working in. We did this. This was a COVID lockdown project. What happens when we can't run animals? We go away and have a look at the literature. And it was a really interesting project. So most studies we found didn't really have any rationale, not scientific rationale, for the dose they were using. It wasn't thinking about the kinetics of the drug versus receptor occupancy. It was based on they had a publication with a significant result. So we've used the same dose, which is understandable. But what we found was the animal doses are typically more than 10 times higher than the clinical doses. And this has been argued as due to hypothesized metabolic differences and stuff, which may be relevant a little bit with chronic studies, not really for acute studies, because an acute study is just a volume of distribution, peak plasma. Metabolism will have a little effect, but not a huge effect. Loads of in vivo studies use only one dose. Very common in forced swim test studies. Depression studies just use one dose. Everyone's always uses 10 mg per kg fluoxetine. That's what I'm going to use. But if you can't show dose dependence, it's much harder to say that you're engaging relevant underlying mechanisms. However, we all do that, though. We interpret the findings by saying this dose is specific to the target of interest. So I just thought I'd show you. So this is an animal equivalent dose calculation that you can use, and I'll show you some data from that, using that. And it just calculates based on sort of allometric scaling. But just to give you an idea, ketamine, one of the most widely tested at the moment, antidepressant drugs. So this is the difference between what we've worked out, a low, a mid, and a high dose of ketamine. So you're talking, this is our kind of 0.1 mg per kg. This would be probably sort of 3 to 5. And this is actually the most widely used. This is a dose of sort of 10 to 25 mg per kg. And you can see at this dose, you've completely saturated the NMDA receptor. So you shouldn't, you know, it's way over, it'll be over 100% occupancy, and you're engaging mu and delta opioid receptors. So it's not specific. And in fact, if your drug isn't working at about 50% occupancy and then with a dose dependent increase, then it suggests it's not engaging the relevant underlying mechanisms you think it is. So too high doses will engage off-target receptors. Now, if you're doing a pharmacological screen, it's not the end of the world because it's about prediction. But if you're starting to ask questions about mechanism, it becomes much more important. And then what is normal? So I've mentioned about stress, but let's think a bit more broadly. So all of our animal models are largely inbred strains. We definitely have suboptimal housing conditions for practical reasons. And we keep our animals in this sort of approach, standard housing, because you have to, lots of animals, small units, got to be able to access them for health and welfare. There are high levels of stress. I was just talking to somebody yesterday at an animal welfare meeting, and we were just discussing actually how abnormal, if I was to say I'm going to do a clinical trial on a novel antidepressant, and the people I'm going to look at are going to be a population of adult male subjects who went at the age of 12 to a boarding school with no parent, no adult supervision, no control, no nothing, and I'm going to call that my normal control, you would probably tell me I wasn't going to get my funding to do a clinical trial. But that's our animal model, isn't it? We take rats at 28 days, we separate them into single sex housing, and we grow them up to the stage we then go on and do our studies in them. So, we've got lots of factors to consider. And also we tend to use a lot of genetic models, which for depression, it's not really a well-aligned genetic disorder. It's gene by environment, and it's quite complicated. So is it surprising that we have poor translational validity? And I don't think it's just depression that has to sort of discuss this, but actually it applies to pretty much all the CNS disorders and psychiatric disorders. So we've got limited readouts, and then we need to think about how we interpret those and the implications. So just focusing in on depression now in more detail. I'm not going to talk so much about the disease models, but I'm going to mention it because it's very relevant. The disease model is different from the behavioral readout. So the disease model is the thing we do to try to recapitulate the etiology of the disease in the animal. We can't do that for depression because we don't know what the etiology is. So the most common thing we do is use stress. We generate a phenotype, and then we sort of trying to look for similar characteristics. So examples are commonly like if you've got a genetic risk factor that's come out of a GWAS study, perhaps use that. Maybe use a pharmacological model, so subchronic PCP for negative symptom schizophrenia. These are things that we can do to the animal's brain that kind of gives it some sort of symptom. Relevant, or environmental models. And I'll talk a little bit more about the examples for depression and where there may be still some challenges in that space. But my focus has been on the behavioural readout. So I'm really interested in designing ways in which we might get a more translational approach. So the reason we need a behavioural readout is that's what goes wrong in that is the expression of most psychiatric disorders. The most common symptoms that we're interested in treating are behavioural. And we need that to be able to show sensitivity to both the phenotype, construct validity, and also to be in the right domain, so face validity. And that's not face validity like the full swim test where we say it looks like hopelessness. It's actually trying to have true translation. I would say that I think that at the moment we've set ourselves a pretty unrealistic target, and perhaps we're not going to be able to achieve all of this. It's very different from looking at and studying something like diabetes, because we don't have a blood marker, we don't have a way of easily understanding our drug effects. So how realistic is it? Well, when we've got poorly understood etiology, we've got drug effects that aren't even consistent in our patient populations, and we rely almost entirely on self-report measures to diagnose only this sort of one disease that's probably much broader than that. It's going to be tough, but it's not without hope. So we'll come to that in a minute. Just returning briefly to our behavioural assays, I've mentioned some of this before, but I just think just really important to highlight the history of these, because I think we sometimes forget. The full swim test was designed in 1970s, and it was developed as a pharmacological screening tool based on the fact that it could differentiate antidepressants from antipsychotics. That was its main thing that it could do, and anxiolytics like the benzodiazepines. That was what it was used for. Yes, of course, it has some face validity. The animals swim around and then they give up and they look like they've developed hopelessness. So that's, but when you compare that to a symptom of depression, you need to be very careful not to over-interpret that or anthropomorphize. It's pretty good as a task for predictive validity for monoaminergic antidepressants. And still, I think even in the UK, where it's come under a lot of scrutiny, we would still be able to use it to look for certain types of antidepressants. Where the problem really comes is when we come to construct validity. We don't have any biomarkers for reference, and equally, we really don't think that actually this assay, we don't even know what causes animals to behave differently in the full swim test. The other problem is it's very good in terms of sensitivity to stress, quite severe stressors as well. Not even chronic mild stress will always give you a phenotype in this, but severe stress will, but not all the other risk factors for depression. So the full swim test and its equivalent tail suspension test is quite problematic now in terms of how we might interpret it for phenotype studies. Sucrose preference test is, again, some issues with it. And the reason there is because people did this in humans. And the problem is that humans don't really show in the moment loss of pleasure. So if you ask people who are with depression, who have depression, about their experiences of reward, what's biggest factor in anhedonia is their reflection on rewarding experiences. It's their memory of rewarding experiences, not their ability to actually experience pleasure. And in a human equivalent of the sucrose preference test, there is no deficit in people with depression. But there is in anhedonia, interestingly. If you just look at people based on trait anhedonia, you do pick something up in that test. But depression isn't really. And so we have a problem when we've tried to kind of relate these assays. It hasn't worked well. So these are the kind of approaches we use to inducing a depression-like phenotype. So we've got the chronic social stress, the social defeat model. This works quite well in male mice, no good for female mice, and doesn't really work in rats, although there has been some work with chronic social defeat in rats. Chronic mild stress, quite hard to reproduce in different labs. And what's happened, which is kind of comes back to my what is normal. I wonder if part of the reason this assay is quite hard is maybe they are already depression-like model. And therefore, to get them more depressed, as it were, and get more of a phenotype, you have to use quite chronic stressors. And from a welfare point of view, it's not ideal, because what you're finding now is that Paul Wilner's original chronic mild stress paradigm, which was quite mild, has now been increased in terms of its severity. So it's now got things, often you'll see it reported with restraint stress, swim stress, and foot shock stress. So it's much, much more stressful. in order to generate a phenotype. And maternal separation, this is a sort of early life adversity model. I personally like this model, probably one of the best. I think it's got that kind of link quite nicely back to early childhood trauma. We also work with an interferon alpha model. This is a nice model because interferon alpha is given to humans as a treatment for hepatitis. It's not now, there's an alternative, but it was. And 50% of them get depression. So it's a kind of good translational model, really. And the other one that I like is the chronic prodepressant drugs, which again, we've got that clinical data that says if you give this drug to human for this long, there is an increased risk of them having depression-related symptoms. That's Roaccutane, which is used for acne, and Rimonabant, sorry, the pictures aren't very good quality. Rimonabant, which was withdrawn from the market. It's anti-obesity drug, CB1 inverse agonist, was withdrawn from the market. What's interesting, though, is if you overlay that by looking at the different tests, you see that the forced swim test, tail suspension test, sucrose preference test, novelty suppressed feeding all come out very well for chronic stress models. They really do. They do very well. And even with the chronic mild stress model, it's a pretty reliable phenotype. The problem is that these other risk factors for depression do not work in these models. Depression-like phenotype for novelty suppressed feeding is the only one you really see with maternal separation. It doesn't really come out in sucrose preference. It doesn't come out in forced swim type models. Some have published it, but it's not consistent. Interferon alpha, I've just been sent a paper to look at, which is using this, but broadly, there isn't a phenotype. It doesn't give, in these classic assays, you don't get a phenotype. And similarly with the drugs. In fact, it was the opposite. So Rimonabant was tested in the forced swim test and showed an antidepressant profile acutely in that task. Okay, so how do we start again? So this is my thoughts for how we should do this, and this is what we've done with one very, very small part of it. But I do think perhaps it sets a framework of what we could do. So I like the idea that we should stop trying to find blood biomarkers, imaging biomarkers, recognize the brain is really complicated, and it's very hard to resolve enough to see those. But what about cognitive biomarkers? If we actually I'm convinced if we could get a concerted effort of a big load of people working in human and rodent work, and we got together and we came up with a load of tasks that we could run in humans and animals that are similar enough. And we can't make rats do human tasks, but we can definitely get humans doing rat tasks. And in fact, they quite enjoy them. So even human foraging tasks, there's a lovely paper come out recently on a foraging task for humans that I really liked the look of. But if we did that, would we be able to phenotype our humans objectively? So no longer relying on these subjective self-report measures that are so influenced by so many factors, but actually having an objective. And I think we'd get a cognitive phenotype that we could then use. And we have this a little bit already, because the one area that's been brilliant for us and working in depression has been that emotional processing tasks have already been characterized in depression and shown to be a really quite robust cognitive biomarker. People with depression have negative affective biases. They have a negative impact, that their low mood has a negative impact on how they interpret emotional information, how they make decisions, that glass half empty, glass half full idea, and learning and memory. And if we take that neuropsychological effect, we can translate it to tasks for non-human animals, because the construct that's there we can work from. Now, human studies use questionnaires, words, language, facial recognition. My rats don't read. They're lovely rats, but they definitely haven't got language skills. And I mean, this is the sort of classic grimace scale. I love the idea of one day trying to show them pictures on a touchscreen and see if they can do an emotional interpretation task. But I think it's probably unrealistic, because I don't even know what a rat's emotional response looks like in its face. But what they can do is they're very good at pressing levers, and they're very good at digging in bowls for food rewards. So we can take the underlying neuropsychological kind of construct and apply it to a task that we know rodents can do. And I'm going to just talk about the affective bias test, but there is a decision-making task that we've also worked on. But in the interest of time, I wanted to just talk through the process we went through with developing this particular task. And if anyone's interested, we can talk about the judgment bias in the question part of it, if you would like to. But that's a sort of decision-making, optimism, pessimism type model. So the hypothesis we started with was affective state. When you learn something, biases your reward memory, and that we could then quantify that by measuring choices for experiences learned under these different affective conditions. So it's a fairly straightforward idea. It's a little bit like a condition-placed preference task, but we give these animals active learning experiences. They have to dig in a bowl and find a food reward. Now, we predicted that if we did this under neutral conditions, that we would get no bias. So these are independent experiences. You have to learn them on different days. But if we induce a negative affective state, even though the reward value was kept exactly the same, what would happen is that these would show a bias towards the neutral, i.e. the affective state would relatively devalue this experience, and vice versa, that we would see a positive shift when we use positive affective manipulations. And to translate that into a task, we have a bowl digging task. So we either do our when we do our affective state manipulation and the rat is learning this has reward in it or this substrate has reward in it, then they have a neutral day. So this is a neutral experience. This is our kind of ground truth, as it were. And then when we do the test, we give them the two previously rewarded substrates. They were equal value, 1 pellet in each. And then what happens is the animal's choices bias that responding. They effectively, they go in, they look at the two subjects, they remember the different experiences, and they have a relative shift towards it. And what's nice is it's a 10% bias. It's about a kind of effect size similar to what you get in human bias studies, affective bias studies. So you get a negative bias when this was negative, and you get a positive bias when their affective state was positive. And because we control for everything else, the only thing that is driving this number is their affective state at the time they were learning it. And we can use this in two ways. We can look at biases that are induced by giving our treatments rather than an affective state. We can actually just give a drug here and say, does it make them positive or negative? But we also, and the thing we've done quite a lot with our psychedelic work has been to generate a negative bias, so generate the negative affective bias, and then give our treatment before the retrieval. Can we modify a memory that's already been experienced? And that's been the real kind of key to this, is that we can differentiate between these different types of antidepressant. So this is a loads of different people's work. It's been going on. We've been doing this for many years, but just to give you a kind of overarching, this is the outcome. And this is a predictive model of antidepressant efficacy and pro-depressant risk. Forced swim test doesn't manage that. So if you do a sort of proof of concept, so if I give the rats 2 pellets on one day, and then we get this nice, clear, positive bias. But if we do all the rest of this, is all just the same reward value. So here you've got antidepressant drugs, and just I'll draw your attention, these are all very clinically relevant doses. So these are way lower doses than you would be seeing used in the forced swim tests, and they're all these are the most effective dose. So these are the maximal effective dose from a dose response curve that we're showing you here. But also it's not just drug effects. So this is social enrichment. So a kind of, I don't know, group therapy for rats, as it were, gives you a nice positive bias. These are all very clearly negative. These are pro-depressant drugs that have been shown to induce depression in people. This causes a very potent negative affective state in humans. Was only used in one trial. Restraint stress. So this has been a big part of our welfare initiative, has come out of this observation that they really don't like being restrained even for a short period of time. And then the court data here, and then interesting inflammation. So this is this kind of inflammatory interferon alpha, and this is a bacterial infection. Interesting, ketamine didn't have any effect on new learning. So these are all biases affecting the formation of memories. But it gives us a nice, clear, predictive and face validity. We then went to try to get construct. Now, construct's much harder, obviously, because as we said earlier, there aren't biomarkers. But the good thing is that there is a biomarker when it comes to emotional processing, because we actually can give people emotional tasks to perform in a scanner, and we can find the brain areas that are involved in it. Then we can go to the animal and we say, right, if we manipulate these brain areas, do we manipulate your ability to do an effective bias test? So we did a number of studies. This is just a sort of summary of a few different papers. So our translational medicine paper, but also our neuropsychopharmacology paper. So we did a lesion of the amygdala, and we showed that our ability to generate positive and also negative biases was attenuated almost completely. Well, it's completely lost for the positive state manipulations if we lesioned the amygdala. So that gave us really good evidence that the amygdala was involved. And what was interesting is we were also able to show that biases associated with new learning were what happened with conventional antidepressants, but not ketamine. Interestingly, psilocybin does affect new experiences, so that was quite interesting, making it slightly different again. So these are three, I've shown these three because all of them work slightly different on affective bias modification. They also work slightly differently when you look at clinical efficacy. The other region that comes up all the time in these emotional processing tasks is the amygdala. It's the prefrontal cortex, and particularly the cortex's effects on the subcortical regions like the BLA. And when we look at this, so this part of the study, we were able to induce the negative bias. So this is the typical sort of what you'd expect to see with a negatively biased memory. And then before we tested the animals, we give the drug prior to retrieval. And what you see is that ketamine very nicely attenuates this. So that biased memory is then attenuated. And interestingly, conventional antidepressants didn't do that. So we think that might be why they have a delayed onset. They can change stuff going forward, but they don't change stuff in the past. In contrast, both the rapid-acting antidepressants that we tested, both could do this. They can both attenuate. And in our Science Translational Medicine paper, we've got this really interesting effect that 24 hours later, we actually see the bias flip. So this negative bias actually becomes positive, suggesting a kind of relearning step. So which is really, really interesting and something we explore a bit more. This gives us face validity because it looks like the brain regions that are involved in human emotional processing are also involved in affective bias modulation in rats. And also it gives us some more evidence towards construct validity, because these are regions that we know become dysfunctional in some of the imaging studies of patients with depression, suggesting that actually increased activity of PFC, certain regions of the frontal cortex, to the amygdala have been implicated in the cause of depression. We also then asked the question about what about construct validity from the perspective of one of the disease models? We've done a number of different models actually, but this one, it was the early life adversity. To me, that is the one that I think has the most ability to have that. The risk factor is is relatively easy to replicate in an animal model by separating the pups from the mother, generating this maternal stress. And we found really some quite convincing evidence that the neuropsychological deficits that you see in early life adversity may actually be a sort of vulnerability to depression. And the reason that we concluded that is mainly this finding here, which is, I think, really interesting. There's this there's this potentiation of the negative bias induced to acute doses of core. So this means that a dose of stress, as it were, that has no effect in the control animals, generated a negative bias in an early life adversity animal, suggesting that there's vulnerability. The control animals would generate negative biases, just needed a higher dose. So this fits with this idea of stress sensitivity. We also, and I'll talk a bit more about the blunted reward learning, we've sort of got a second assay now where we look at that reward learning, because it turns out that that's actually very clearly blunted in our early life adversity animals. And again, this is a translational task, because if you ask humans to do reward learning tasks that are similar to this, they also show this blunted. And we call it a reward induced bias, because the reward experience should induce a bias towards the higher value reward, but only if you can remember that, and only if the reward value is properly integrated into your memory. And just out of interest, because we did a quick correlation and we're very surprised to find that even with a low N number, we see quite a tight correlation suggesting this blunted reward is also linked to this sensitization of the stress system. So this gives us some indication of construct validity. And then just to show, because I think it is important, and it's great if you have the opportunity, like we did, to work with the group in Oxford who were doing these emotional tasks in humans. We could just literally say, what are you doing? Well, let's test it. And not everything we test in animals can be tested in humans, but a lot of the drugs can be. And so interestingly, we get exactly, I like the fact that the actual, even the sort of order of magnitude of effect is similar. So we see rimonabant, citalopram, mirtazapine working in humans here, rimonabant negative, and we see exactly the same in our rodent model. So these are 3 antidepressants. This is a prodepressant, having this really nice. So this gives us this idea of translational validity. And then we go to try to look at the bigger picture. So, you know, we see a biologically relevant effect size. So our effect size with the meta-analysis is 1.25. So similar mean differences to what we'd expect to see in emotional processing tasks in healthy volunteers. And we, in theory, are using a healthy rat population. Clinical relevance, the doses that we use, for a start, they're all dose dependent. So we see a clear dose dependent relationship in both the prodepressant and the antidepressant ones we test. And our maximal effective dose is usually close to what we would expect is getting a sort of 80% occupancy in the human, based on where we can find PK data. But I completely can see why people struggle with this, because we've really struggled to find that data. And I've had to sort of talk to industry collaborators who have the data, but it was never published. So we can sort of utilize it, but we don't, that really good literature is missing. And we run with sample sizes of about 12 for one factor or 16 for two factors. But this is the dose data, which I think is really interesting. This is an outcome of doing an analysis of all the different doses that have been used in the full swim test. And you can see the huge range. I mean, this is fluoxetine, where we found, literally anything from 0.1 mg per kg all up to 100 mg per kg was not, the huge range. Most common, 10 mg per kg. 10 mg per kg was pretty common for most antidepressants, actually. But the crosses you can see, this is the animal equivalent dose calculated using the formula and our effective bias dose, and they align really, really favorably, incredibly favorably. And just to show you, these are our dose response. You can see that they max for fluoxetine is 1 mg per kg, it comes down at 3, and by 10 it's actually down here. And again with ketamine, maximal at clinically relevant dose, 1 mg per kg, 10 not so much, and by 25. I mean, main problem at 25 is it's a very high dose. They don't really know who they are anymore. And the last bit I want to talk about is just very briefly is the reward learning assay, which, as is, I'm not going to pretend it came out of a planned set of studies, because it didn't. We literally were just messing around, and training animals, and we always train them using this 2 versus 1 to check they could do the assay. And we did a study with a chronic pain model, and we were like, why doesn't it work? And then we actually looked at the data, and it was only the animals that had chronic pain that had stopped being able to run the task. So we then thought that's probably a real effect. And the prediction is, and if you go to look at the literature in the humans, actually it's quite clear that we could have predicted this, because we set up a memory where they have a high value experience, we set up a memory where they have a low value experience, and then we ask them to compare the two, which do you prefer? And a normal healthy subject should be able to make a preference for this high value, and that's what we'd expect. And then in depressed humans, you get this sort of blunting of this reward learning, and it's much more about reward related cognition than it is about sort of sensitivity to taste, like the sucrose preference test, and it's blunted. I haven't got the data in here, but just to say that actually, if you take animals and you enrich them, we can put it right up as well. So this is definitely not maximal. There is capacity to go higher. But the data are really different from what you see when you look at sucrose preference tests. So here we've got 4 different models of depression based on different risk factors, from early life adversity, stress, and drug treatments, and they all induce this same thing, blunted reward learning. But only the chronic stress model gave an attenuation of the sucrose preference test. We didn't find anything in early life adversity or interferon alpha or retinoic acid, and that's not unlike the rest of the literature, that people found sort of something not dissimilar to that. And then we also ran a drug study, and what's really nice is we were able to induce the phenotype. So this is an interferon alpha model where we start off by inducing the phenotype. We then split the population again, so we checked that all animals had appropriately developed the phenotype, and then we saw what would happen if we could reverse it with chronic venlafaxine. So we were able to reverse that reward learning deficit. And in fact, we've right recently done some work with psilocybin and shown that we can get this to happen within 24 hours with psilocybin, fitting with this rapid acting antidepressant effect. So again, tapping more into the cognitive aspect of reward rather than that kind of sucrose preference test approach. Okay, so I want to give us plenty of time for discussion, so I'm just going to summarize where I think we've reached. So I think that traditional methods to quantify depression-related behaviors, so we had them for a reason. They certainly can serve that purpose, and I don't want this to feel like it's a criticism of all the kind of past that's used them, because I don't think it is. I think there's a lot that we can learn, but the problem is that I think now, as we understand more what we've been studying when we use these methods in depression related phenotype type work, is we've been studying stress biology. And that stress biology may have some relevance to human depression, but it's also unclear whether the type of sort of psychosocial stress, the sort of chronic mild stress we talk about in humans, is the same as a chronic social defeat model. Taking a rodent and spending 6 weeks exposing it to forced swims, foot shocks, restraint, which are quite severe. And does that really give us insight into human depression, or is it just telling us that if you really stress out an animal, these are what happen? I would argue that given the lack of translation now of those kind of studies, as well as the fact that only that chronic stress model gives that phenotype, we should be questioning really whether or not tasks like forced swim tests, tail suspension tests, sucrose preference tests can really be helpful if you want to study mechanisms and you want to study identify novel drug targets. I'm really surprised because I'd never thought of it. I've been in the field for 30 years. I'd never thought about, I've just done the same as everyone else. I was told that rodents have high metabolism, you have to give high doses of drug. We get a translational task and suddenly we find that all our drug doses, and we started off with high doses, don't get me wrong, the animals were deaf, but the animals wouldn't even run the task. So we had to lower the dose because at 10 mg per kg fluoxetine, they refused to play, even do the task. And then once we got the dose response data, and it's been the same with clinically with the psychedelics, with ketamine, they're all in the clinical dose range. You know, our most effective dose of psychedelic psilocybin is 0.3 mg per kg. That's what's being used in clinical trials. So these high doses engage molecular mechanisms that are just not involved at clinical doses. So I think even when it comes to, you know, interpreting the data, we need to think about, is this dose actually engaging a relevant population of receptors? So the typical dose of the typical dose of fluoxetine is 10 mg per kg. In humans, the total dose is 20 and if you assume an 80 kilo man, then you're talking, you know, doses of 0.2, 0.3 mg per kg. So really, you know, a lot lower than this, and therefore will be occupying a very different receptor population. I think the ABT and the reward learning assay have shown that you can do these. You can provide objective measures of both short-term and chronic changes in affective state, and that they are more translational. However, they're ball-digging tasks. They're notoriously difficult to run. And they're certainly not a replacement for something like the full swim test, which is something that many different labs could use. It's very reproducible, etc. And that's our challenge. How do we move that forward? So I think we need innovation in animal models to, you know, I think that's been way behind this kind of classic technology advances. You know, we've got beautiful ways to manipulate the brain. And I would argue, I'm great for this behavior forum. I'm sure you'll all agree with me. We need investment in behavior. Behavior's been sort of coming along in the background. We've all been making tasks and testing them in our own time almost. Nobody's funded this big initiative to sort behavior out. So hopefully we can change that. We need to understand what's normal. I really think that actually our rodents are a very good psychiatric model. And if we change the perception of that towards having better controls, maybe we would then have better psychiatry phenotypes anyway. I think it is possible to develop better readouts. It's not easy, and I'm not saying ours is perfect by any means. There's plenty of challenges with it. But when it comes to testing it, it's tested itself very well. We haven't found a massive problem with it. We haven't. Whereas, you know, all the other stuff I found, you can always find a real caveat to the interpretation. So we need investment. I would push for investment in methodology to quantify psychiatric symptoms, which I think will benefit all studies in animals and in humans, and this idea of cognitive biomarkers. And I finish off just by a plug for my 3H's initiative. It's worked for us, and we only got the 3H. The initiative came out of the fact that we had to adapt our management of our animals so that we could actually get effective bias readouts. Because if our rats are stressed, we can't see any effective biases. So I would argue that perhaps this is a framework that's not just about improving the welfare of animals, but perhaps we could use this in the context of getting better rodent models for psychiatry. And I will finish there. Thank you very much for your attention. And I would love to hear people's sort of discussion thoughts on it. I'm not sure I know the answer at the moment.